Hey everyone. So my name's Nick and today we'll be talking about Orthopaedic Triage, and I'm joined by an esteemed group of guests with me today. So we got Jay, we got Navi, who's a new guest to the podcast, so welcome. And we got Jason, an experienced member who you should all know.
The veteran of the group.
Fresh after Nick and I all fresh after Oskies, enjoying life and watching these two suckers just...
Yeah, the stress, you can see it on their faces.
Bags under my
You may be able to hear it in their voices today. Yeah.
But yeah, today we decided to talk about triage in the orthopedics context because last year, and years prior leading to that.
There may or may not have been.
There may or may not have been.
And it was also the most voted for when I did a poll in the group chat.
Exactly. There may or may not have been rumours that triage stations are a recurring theme in the MD3 OSCE. And last year they may or may not have put an orthopedic spin on it.
We don't know. Memory,
this
man.
is all rumours going
Forgotten
around.
everything already.
Yeah. I mean, are we technically done? It's already too late.
Yeah.
Once I get that certificate, we'll be fine. So basically, I wanted to go through the triage station and what are the important sort of things you need to keep in mind when going through it, and how to really break down those two sort of conditions that you can't seem to determine which one takes priority over the other, because they always seem to have two that really seem they could claim top spot. So we'll go through how to break that down in a moment. I'd just like to start with sort of the concept of triage and basically what it means, because we all think we have an idea of what triage is. And so to start off with, the etymology of the word comes from the French verb Cheyurr.
Yes. JT.
JT's frothing.
JT is forced Nick to bring this.
So it's the French verb Cheyurr, which means to sort. So there we go. The definition from the Oxford...
we only use good quality sources.
Yeah,
here.
exactly. We're going about top tier stuff here. It means the preliminary assessment of patients in order to determine the urgency of their need for treatment and the nature of treatment required. So from that definition, I sort of chose three important words from that. The first being preliminary assessment, the second is urgency, and the last is the nature of treatment. And why I thought these words were sort of important is preliminary assessment means using the limited information provided to you, i.e. in the OSCE case, to make a diagnosis to determine basically how the patient fits in the tier list in the context of the other patients.
So like little prompts, right?
Yeah, they're prompts, and it would be around 2 to 3 sentences max, with a bit of a history and maybe some examination findings and some vital signs. So that's your preliminary assessment, where they give you the bare bones of the patient. Then the second part is urgency, and that's your role of basically to stratify the patients based on the rush to get the patient fully assessed and managed. And then the last bit of that is the need and nature of treatment. So this is the way I interpret it. Can they be left alone for the next 24 hours? And if they can be left alone for the next 24, 48 hours, they typically find their way at the bottom of the list. And the opposite of that, if you ask yourself, is if I do nothing, will the patient die? And if you're answering yes, then that patient should go towards the top. Death
should be avoided, Jay. That's
death
one of the
bad.
roles as a doctor, in case you
I think that's a bad thing. Yeah. So I've got some tips as we go along the episode, and my first tip for the day is there's always going to be a complaining patient that's angry, in a lot of pain, and they really, really need to see you about something. And those patients are not an emergency. They never are, and they will always find their way down to the bottom.
So if you could talk, you're on the bottom.
Yeah, exactly. No, you're so right. If
GCS above 8?
Yeah.
It's true, though. You kind of need these little tips because you've only got a few minutes to sort out your preference.
Mm-hmm. Your prompt simply just says, you've got 5 patients that have come in. Please review their notes and prioritize them.
As bad as it sounds, you kind of need that pattern recognition.
Yeah. Exactly.
Have in your mind some of those classic orthopedic prompts.
Yeah, exactly. And also important things to see on the context. Are they screaming in pain in the ED just coming in? Is that part of their presenting problem? Or have they just been on the ward?
And technically, I guess medical-wise, to explain that, if you can talk and ask for the stuff, it means your GCS is pretty high, right?
So I guess from that sense, working out who sort of fits in the bottom, I think is more of the easier part. And then you get sort of to the upper part of it where you've got 2 to 3 and you don't know whether it goes, 1, 2, 3 or 2, 3, 1, etc. So I wanted to go through some of the classic orthopedic conditions and where you guys think they typically stand in terms of in general.
But just ask around the table, what do you guys think are the main like orthopedic condition?
Yeah, that was mine. Yep.
Compartment syndrome.
So like unstable pelvic fractures.
Yes,
Yep,
yeah.
cool. Anything else? We got a few more.
Hey, we've already done an orthopedic exam.
Osteomyelitis, septic
Yep,
arthritis.
yep.
Long bone fractures, again, the
Yep,
same thing with like
cool.
bleeds and things.
Yep.
Enough, I guess. Not life-threatening, but
Yeah.
quite serious.
No, it's very serious, yeah.
Yeah.
You could have things like really displaced clavicle fractures with tenting of the skin and all that sort of
So you mean open fractures?
open fractures
Yeah.
as well. Yeah.
Yep. Perfect. Great. That's literally the list I have here. I've broken it down into emergency ASAP, urgent, so within the next 12 hours, and then acute, so within the next 24 hours. And the emergency sort of ones you want to address ASAP, like you said, was the compartment syndrome, your open fractures, like high energy mechanism traumas, so your C-spine, open book fractures, long bone fractures, septic arthritis, and then any sort of neurovascular compromise. My next sort of task for you guys is, would you be able to provide like a classic 1 or 2 line history or presenting complaint that would fit some of these conditions, just so we have in our mind what the pattern of them are?
Inevitably, like on the day, if you do get them, you really need to have those prompts
It's
in
all
your
about
mind.
pattern
because-
recognition.
It
Yeah,
is.
it's not about
Exactly.
you don't have time to figure it
Yeah.
out. Essentially, you need to just recognize it straight away.
So I guess the most life-threatening things are like your high trauma.
Yeah, like what would you sort of expect to see on the prompt, 2 to 3
Well,
sentence
like this
prompt?
person's this came in after a high MVA or something.
Yeah,
Yep.
So anytime you see MBA, you're always suspecting high trauma.
Mhm.
That's a good word to remember.
Like the bruising on their hips, they're
Yep.
hemodynamically unstable, blood pressure's tanking, heart
Yeah.
rate's
Yep.
going up. They look like they're about to be shocked.
Are
Yeah.
there any
Shock-
fractures classically associated with MBAs?
Hip, pelvic fractures.
Pelvic.
Yep.
Yeah.
Yep, great. And some other things you might notice is they might have, I can't remember the medical name of it, but they might have blood coming out of the urethra, or they might have damage to their perineum, which is very classic for that sort of pelvic injury. What would be a classic presentation or 2 to 3 sentences of a compartment syndrome patient, Navi?
So they could be of any age essentially, but in terms of past medical history, they could have had a recent fracture that they've got a plaster on, or any other sort of injury within the limb.
Yeah, great.
And then they've sort of developed this pain that's out of proportion from their injury. They could have, once compartment syndrome starts to progress, they could have like altered sensation in their limb. You could perhaps see visible swelling as well, change in temperature, like loss of the pulses. I think it's your 6 Ps, but I always
good
get them
job. I
muddled up
see.
in
So
my head.
the 6 Ps are definitely worthwhile to know, but I'd expect they wouldn't really give them to you.
No, I don't
So,
think
Yeah,
I would.
but
Okay.
you mentioned a few key ones, and from what you just said, I reckon that the plaster on the arm is a classic one, and the pain.
Yep.
Because it just may be like a distal radius fracture,
Yeah,
they've said,
yeah.
and then they've got that plaster is really the key
Yeah,
one.
yeah.
I reckon,
I think the other
and
classic
pain.
presentation for it is it'll be like someone's 12 hours post-op and they're becoming increasingly sore, and you've reviewed them and there's no obvious wound infection, and they're just increasingly using their PRN analgesia. That's another classic one. Post-op.
So there's these little bits of information, but
Yeah.
100%.
as bad as it sounds, remembering plaster, you're like,
Yeah.
pretty confident it's going to be.
Yeah.
And then your septic arthritis patient, I think we'd all be pretty confident in identifying that.
Might as well go through it. What are some things which they could put in?
Mhm.
have a fever,
Yep.
limp, not weight bearing.
Mm-hmm.
They look
Hot,
toxic.
swollen red joints.
Yeah, great.
Any history of like trauma to the area? Is there like a draining sinus from
Yeah,
it?
cool.
Could be IBDU.
Yeah, great. Risk factors.
And like other immunocompromised, I guess, diseases, type 2 diabetes, that sort of thing.
Yeah, great. And then taking a step down, even though this is still quite high up on your list, it's not quite that tier 1. We've got things like your neck of femur fractures, people with multiple fractures, someone showing signs of progressive neurological deficits. So someone that's starting to say, I'm going to feel a bit pins and needles, because that's one of the first signs, because the swelling starts compressing on the nerves, and then you start getting that sort of paresthesia.
And one of the things you can get tricked by is that I think we've just been hammered in that compartment syndrome. Yeah. Oh my God. It's like the worst orthopedic emergency.
Yeah.
But on the other hand, you got to keep in mind that there's more to the body than the bone.
Exactly. And I think, to be fair, compartment syndrome does have a high mortality rate, because you get muscle necrosis and you get rhabdo, and that can lead to a whole bunch of things. But septic arthritis is probably going to be, I think, a little bit more serious, just because
It's just like anything which can cause hemodynamic
Exactly.
instability always takes.
Yeah, exactly. just like to take another step down. So we've gone through the sort of first, second, and now we're on the sort of third tier. And these are your things like, wrist fractures, ankle fractures, scaphoid fractures, tibial plateau fractures, any sort of general fractures that aren't open or significantly unstable. I think those would sort of be those ones where you put them in the middle. They don't require attention within the next 20 minutes, but they're not something you can just come back to in 48 hours because,
But if they did have some sort of vascular compromise, would you move them up to the...
Absolutely.
Right.
Yeah, definitely. I think if you're going to get 2 fractures in terms of it's not a NOF and it's not a pelvic fracture, the best way to determine is basically the x-rays, because in your triage station they'll have the description of the patient and then an x-ray underneath it of that injury, and that's what I was going to we'll get onto that in a sec. You've got to use that x-ray to then either confirm your suspicion that this patient's really sick, or basically be like, actually no, that doesn't actually look that bad, maybe we can consider putting them down a little bit more, less. Yeah. Yeah, paracetamol, go to bed.
Walk it off. Yeah.
And then the bottom of the list stuff we've already established. It's your screaming up in pain patient. It's your elective things, so soft tissue like tendon or meniscus repairs. Someone who needs hardware removed because it's causing irritation. I wanted to talk about just briefly, because they might give you this, someone that's come in with an effective prosthesis. So someone's come in, they're complaining of pain in their hip, and they've discovered there's actually a collection in their hip replacement. Where do you think they would sort of fit?
Well, because I know the prostheses, they're prone to biofilm formation, so the antibiotics are not going to work. So you probably want to get them into theatre as quickly as you can.
Yep, definitely. And so they'd probably find themselves towards the upper part of your triage. Again, are they septic? Is there a sinus that's actively draining anything? Just something to consider, because they always try and throw a curveball in there somewhere. I wanted to briefly talk about scaphoid fractures very quickly, because I think there's we all know why they're potentially dangerous or bad because of their risk of avascular necrosis. And the thing is, do you know how quickly that onset of avascular necrosis is?
From memory, it should take a couple of weeks, 1 to 2 weeks.
Yeah, it can take even longer, months as well,
Right,
depending
okay.
on how proximal the fracture is. So if it's a really proximal scaphoid fracture, you're talking weeks. But if it's sort of in the waist of the scaphoid or distal, it might take months or if not at all. And the thing is, I think a lot of students avascular necrosis will put them up because we don't want them to lose their wrist, basically. But it's a slow process. So just remember that it takes a few months to weeks for that scaphoid fracture to lose its blood supply. So yeah, probably a good one to fit in the middle somewhere. Depends how long they've come in after their injury. Yeah, my second tip was, if you get stuck between 2 patients for top spot, look at their vital signs. Are they deteriorating? Are they already actively shocked? It's a really good tip.
Do you think you could pass the station even if you get those first 2 mixed up, as long as you explain it? Or do you reckon
So if you put the second one first and the first one second, but I think a lot of people did that in our year group because no one had done any trauma. And I don't think you'd foul on those grounds, because I think as long as you can manage them, I think it's fair. I don't know whether they would drag your attention and be like, hey, can you tell me how you'd manage your second patient? And then you'd still get the marks for it. I don't know. I think it would be a fail if you put one of the bottom ones at the top. Yeah.
Because they just want you to be safe, right?
Yeah, exactly. Yeah.
Another bit of words of wisdom, because this is from my experience of that same station. I ended up passing the station, but I got lucky because the examiner kind of helped me. So initially I got the order right, but then I finished 2 minutes early, and I'm you're still thinking about the station whilst the examiner's sitting across you, and I was like, oh, do I change the order? I was going to change the order, and the examiner just told me to shut up. Literally told me just stop talking.
You're digging a hole.
And I was like, okay, I'll stop talking.
That's
just sat
so
there in
good.
silence for 1 minute and still got the pass. So listen to
Where'd
your
you do it?
examiner.
So we've got a wide variety of experiences, because my triage ended up being pretty all right, I think.
That's why we're getting you to teach it.
Yeah,
We only got Adian left for his experience. What happened with that, we don't know. We'll never find out.
But I think you'll pass as long as you explain your rationale. You probably still get a pass. But anyway, sorry for the sidetrack.
No, that's all right. It's good to sort of talk about that so the listeners feel better about themselves. So we're going to talk about the investigations, i.e. x-rays, because very likely they will give you, along with the case description, an x-ray of that pathology. And it's really important for you to be good at reading x-rays quickly, because there's going to be at least 4 of them. And so I wanted to sort of ask you guys, do you have an approach you guys use to MSK x-rays that we could quickly run over?
Are we talking like systematic, like OSCE style, or just like this is what the diagnosis is?
Do you have like a little spiel, right?
Spiel, yeah.
Oh, yeah. So basically, where is it right now? Are we in the pelvis? Which bone is it? Is it what view is it?
Yep.
Is it rotated? Blah, 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 blah.
Yep.
The most salient finding is this, this, and this. I want to get an x-ray of this, this, and this, and then describe what the fracture is like, basically.
Yeah, cool. I think for this, because there's so many cases to go through, they'll just ask you for your first impression.
It's spot diagnosis.
It is. They won't get you to be like, there's no soft tissue swelling, or there's no this, no this. If it is there, call it out. And maybe if there's any relevant negatives, like, you know, important relative negatives, I can't see any like air under the soft tissues, which suggests to me this isn't an open fracture, anything like that.
You got to really read the room, because sometimes I think you can get bogged down doing your whole spiel, and that may take
like
3 minutes.
As well,
and
exactly. You may not have enough time, so you need to get to the point a bit. And sometimes, like, you know, everyone does the demographics, like this John Smith, age 20, whatever. You can say that whilst you're thinking in order to kind of save time.
Yeah. No, exactly. That's what I was going to get to, which is this sort of station requires you to deviate from your normal, this is an x-ray of blah, 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 because there's just not enough time. So you really just have to call it out and move on. Just be like, cool, that's a neck of femur fracture. It's inferiorly displaced, blah, 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 I don't know. And just move on. I think that's the important thing for the x-rays.
Okay, would you still say something along the lines of, ideally, I'd like to systematically review all of the x-rays, but given this is a triage situation,
yeah, I think there's nothing wrong with that. Okay. Yeah, and you can also be like, I'd like other views of as well, because for our pelvic one, you know, with all pelvic fractures, there's a good way of thinking about it. It's in a circle. So there's a break in one part of the circle. There's likely to be a break in the other part of the circle.
Yeah.
And so for that pelvic one, I was like, I'd like a lateral and or another view of the pelvis.
It's just an issue of time and thinking about like how many points, right? Like saying that statement may help with the global, but
do you have to like manage all of them or just the one?
We had to manage all of them because there was 4. But if there's more than 4, I doubt it. They'd probably get you to manage maybe the first or second one. But they get increasingly easier to manage. So once you get the first one out of the way, which is probably worth the most marks, the second, third, and fourth one get easier to manage. I think the OA one, you're like, you know, analgesia, refer to, Pat Boy. Exactly.
Having a structured approach definitely helps with interpreting it, but in a sad way, it's really important to just know those prompts and know what common fractures happen in each area.
Right.
Because you can almost make an educated guess before even seeing the image what
also,
the fracture will be.
Also, they're probably going to give you like common, not like a weird, like tiny break somewhere. It's going to be like a very obvious fracture that you can see on the x-ray.
Yeah, and x-rays help in terms of if there are multiple patients with multiple fractures, then you can sort of work out the stability of them using those x-rays. So the ones with the less stable fracture would probably take priority. So as we said, these stations, the cases aren't given to you at the front on the door, which is really annoying because you're like, well, how can I prepare? So I'd like to just go over very quickly, what are some things we can do? So obviously you get into the room, you'll read the cases, you'll look at the x-rays, you'll triage them in order of your severity and you'll justify them most likely. So what are some things maybe we could talk about that could help someone in those 2 minutes before entering the room, that could help maybe prepare?
Write down a quick management plan for like, this is an emergency, do an A2 assessment, blah, 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 blah.
Yeah.
And then like for least important, like you can write Paplio down. All that stuff.
Yeah.
For most of your like acute management, for when you need to take patient to theatre, you could just quickly note down like all of your pre-op.
Yeah, cool.
Your pre-op steps, because that's something that I feel like if you don't have a good structure to you should a bit all over the place.
No, I agree. You should be able to ramble off your pre-op stuff in like 10 seconds. But I want to do this.
Also, on the pre-op like vibe, I don't know. People forget to ask when their last ate.
Yeah. So like fasting status,
stuff,
I put that with my kneel by mouth. So I say keep the patient kneel by mouth and check fasting status. I don't know. That's the way I remember it to do it. The other way I wrote down is maybe write down some of the important red flag conditions you don't want to miss at the top of your page. I know it's really easy to that right now. We're like, obviously we know them, but sometimes when the pressure gets to you, it's really easy just to go blank. When you have it in front of you, it's there, because I don't know about you guys, but my mind goes blank in the OSCE.
I was going to say, if there's no information, it may be a good chance to kind of take a deep breath and relax with it.
Yeah, sure.
Like a minute to calm down, a minute just to think, and write stuff down if you need.
Yeah.
Because really, a lot of these triage stations, if you have a clear mind, you can really figure them out. They're not too complex. It's just the stress, essentially.
It's the stress, and you question yourself. So the next thing they'll ask you after sort of prioritizing your patients is your management. So let's briefly talk about maybe a really good way that you can approach your management sort of principles, maybe a structure. Do you guys have a structure that you use?
Always start with an A to E
Yep.
assessment.
Mm-hmm.
Gain IV access, take some bloods.
Yep. Great.
Check, give fluids if they need it.
Mm-hmm.
Order the MTP if there's a massive.
Yeah, sure. Like a trauma. Yeah, nice.
Do if it has, you said if it's a pelvic fracture, you could. The one thing we were told to do is always do a pelvic binder. It's pretty easy to do. And that should be part of your A2E assessment as well.
Definitely.
Just a pelvic binder.
Yep.
Then check the because it could be like a head injury or something.
Do you know what you'd do for a long bone injury in a trauma?
I've heard about a traction splint if it's like a femur fracture. Not sure,
You would probably get a femur. So that's it. Yeah, and it's basically what you just said. So it's good you know that. So you sort of got your resus, your first sort of thing, and then what comes after your resus? What are the sort of steps you need to take?
Get an X-ray of the fracture if it's not already done.
Yep.
And if you don't know the exact management, you can always say, I refer to orthopedics for the management of this. It's likely it could be blah, 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 but I'll let them decide.
Yeah. And if you don't know it, you can actually get really far with just, I'd like to resus the patient A to E and then symptom management will give them some analgesia. And then there's some operative and non-operative things we can do for them. So operative, I'll refer them to ortho, prep them for theatre. Non-operative, I'd give them antibiotics. Maybe it's like a open fracture or something. And already you've got a really good structure there. And then with any ED case, they love disposition. They want to know where the patient's going. So you'd say this patient's disposition is theatre, and then likely afterwards ICU, HDU, or ward-based care, depending on the severity. And if you've gone through that without having a single clue how to manage it, you'll definitely pass.
Yeah, it's great because I feel like a lot of these surgical cases, if you have a good spiel for your management, you can apply it to pretty much all these cases.
Absolutely. Yeah, definitely. And this structure that I've got, resus, symptom management, specific management, and then disposition, can be used for any surgical specialty in the end of the day. So you can apply it across different ones and make sure you cover all the bases with the patient because, you want to make sure you give them analgesia. You want to make sure if they're feeling nauseous, then you give them something for that. Just basic stuff. So that's the last thing I sort of want to talk about. So make sure before you start talking about your management, have a quick look over your sort of triage. If you're happy with it, then start talking because as soon as you start talking about your management, it's locked in. You can't change it. Maybe the examiner's nice and you're like, actually, I've just realised. Maybe they'll give it to you.
They're trying to guide you and tell you to not
and tell you to shut up.
Yeah. Listen to them.
Yeah. I was Osborne Park. It was really nice.
Slap you.
Yeah.
I walked in and he hadn't rearranged it from the student before me, so I was like just sitting there and I was like, that looks pretty good. And he was like, oh, sorry, I've got to change it. I said, no, leave it. I'm happy with that.
And these aren't some high-tech images like 1080p
laminated.
resolution. They're laminated ones, man.
On A4.
It is hard to tell sometimes. So just make sure you know your prompts really well.
Do you know that X-ray I put up on my lecture about the talk, that chest X-ray that was so blurry and fuzzy? Yeah, that is the stuff we're going to get.
So
140p stuff.
140. That's generous, mate.
You got to take in the context for sure.
Yeah.
Otherwise, you will struggle to find those fractures.
Just like you said, pad recognition.
Oh,
yeah, 100%. Yeah. So, any sort of questions about what we've gone through at the moment in regards to triage stations?
Yeah, just people struggle with structure.
Yeah.
Getting it. You're like, oh, this, and then I'm like, oh, I remember that, and then they jump around.
Yeah.
I think most of us can figure out what's most important and what's least important. Issue number one is ordering the ones in between. And then the second issue is trying to figure out what is more important between condition 1 and condition 2.
Yeah.
So, yeah.
Yeah. No, that's completely fair. I think that's a recurring theme every year. And the thing that you've got to remember for sort of that middle of the pack is, I divide it into the top 2 are going to be your immediate sort of things within the next couple hours. Your middle ones are going to be within the next, say, 24 hours, and the last bottom 2 are going to be things you can leave for maybe a day or 2. And that's the way I think of it.
And I reckon it's probably a common thing where you realize halfway, maybe you explained your first option, now you explain your second, and you realize the order's wrong.
Yeah.
I feel like you can go back and be like,
definitely.
I've realized this patient's hemodynamically unstable. I would actually put them on the first. You could save it. So make sure you still explain your logic when you're doing these questions.
I reckon it's a good habit to get into. Even if they don't ask for a justification, do it anyway, because then they can sort of give you marks where maybe if you didn't have...
Because you can see your train of thought, you actually realise this is compartment. That's why you put it first or second, even though it should have been second.
Yeah, definitely. I was just going to cover something that got asked on the SGR, which is, do you put compartment syndrome or septic arthritis first if you got both patients in front of you? And I know it's a really contextual
really
question.
Niche, yeah.
It's very contextual because I was like, well, it depends on this. Basically, I looked up the mortality rates between the two of them, the percentages, and I was, okay, so septic arthritis, I've already linked the references in for this, but they found that it was a 7% 90-day mortality rate for septic arthritis. And if they're over 79, that rises to just under 23%. So if you've got an 85-year-old with septic arthritis, I'll probably put them towards the front. The compartment syndrome, on the other hand, was around 6.6, and some studies saying it's as high as 15% mortality rate. So it's lower, but it's still very high. So it doesn't really solve much, but it does give you an indication.
I guess, like you said, it would be more important now to check like the vitals.
Absolutely, yeah.
Because I guess the only thing you could be concerned about if you can go into septic shock from the septic arthritis.
Yeah, I found some.
Is it common for people who have septic arthritis to go into septic shock though?
Yeah, so what happens is I think the joint starts degrading beyond repair within the first 8 hours. So if you haven't started treating it within 8 hours, they've lost their joint cartilage forever. And then I think if it's only a few hours after that it starts to spread. So that's all I wanted to sort of talk about, and just wanted to quickly address that question. You guys will be fine. You've said some good things that I would not have said as a third year, so you're way ahead of me already. Maybe we could just go over maybe the important aspects of it, because I did sort of deviate from the usual structure of these podcasts, and that it wasn't a condition.
How rude.
I didn't really talk about the audacity to come onto this podcast and not talk about the first principles. Maybe we could go around and say one thing that they'd like to sort of reinforce home.
A life over bone.
Life over bone. I like
exactly
that. Life over bone.
Life over limb. Yeah, that's
life
good.
over limb. Life over bone.
Can we trademark that? That's good.
Maybe that's going to be the title. Life over limb.
Yeah.
There we go.
Even for like urology, life over balls.
He's really going back to that one.
You could trademark that as well.
God.
This is oddly specific.
No, I did. My friend failed it though. That's why I'm thinking about it.
Oddly specific, man. The last thing I want to say and sort of reiterate is your management structure.
If we just gave you an example, like let's say a patient's come in with just a simple distal radius fracture.
Yeah.
Can you give me your management spiel, you would say, in an OSCE?
Yeah, so I'd say, bearing in mind that this patient's stable, I would do a quick A to E to ensure that I address any immediate medical emergencies, if there's any associated other head injuries that they fell or whatever. And then once I've stabilised the patient, I'd like to give them some analgesia using the WHO pain analgesia ladder and titrate it to the level of pain. I'd give them some antiemetics as well to counter the side effects of the analgesia. This is bearing in mind I've got the X-ray and it's not an open fracture that needs immediate operation. I'd treat them non-operatively. I would contact help and I would ask the anaesthetics team to help with a Beers block. And then once I've got the Beers block in, I'll mobilise the joint and locate it. And I guess operatively, if it goes wrong and they start bleeding or something like that, maybe. And then disposition for them is fracture clinic, follow-up, but the orthopaedics team, safety net, handout, re-X-ray them, reassess their neurovascular status, and monitor them as the Beers block wears off. Cool. I think that's the way I'd sort of go about it. Yeah. So if it's like an elderly lady, you'd be like, follow up with your GP for osteoporosis, the DEXA scan, all that stuff.
There was another question I saw. I think it was me who asked it about the neurovascular assessment.
Yeah.
And I remember this thing a reg taught me. It's like, make an AOK sign, make a gun, make a star.
Yeah.
If they can do that, they're all good.
Yeah, that's the sort of neuro side of it.
Yeah.
That's upper limb as well. Yeah. I was going through a quick neurovascular assessment, how to do it.
I think it was in the previous episode actually.
Was it? Yeah, for the upper limb it was. Yeah. And just to recap that, if you want to assess the vascular, it's 3 things. It's very easy. You want to assess temperature on both sides, cap refill time, and you want to assess the peripheral pulses. For the neuro side of things, you want to assess sensation in the distribution of the ulnar median radial nerve. You're going to assess the movements, and then that's pretty much it. And maybe grip strength, because that's all of them. Cool. All right. If that's everything, thank you so much for listening. I'd like to thank my guests for this episode, Jason, Navi, and Jay. Thank you so much for contributing and sharing some really insightful pieces of knowledge regarding the triage, and all the best for your OSCEs. You'll be fine.
Thanks, Nick.